Welcome. We are delighted to present this series of educational videos, Pituitary 101, featuring Dr. Lewis Blevins, a program exclusively produced by Pituitary World News with important information about the systems that drive pituitary function and, importantly, how those systems are affected by pituitary disease. Here's Dr. Blevins.
Welcome to this episode of Pituitary 101, episode 6, the hypothalamic pituitary gonadal axis in men. I'm Dr. Lewis Blevins of Pituitary World News. Thanks for joining me today. I'd like to discuss with you the intricacies of the hypothalamic pituitary gonadal axis in men and help you understand some of the things that we consider when we evaluate patients with pituitary disorders who might have disruption of this particular axis. If we can turn our attention to the first slide, you can see here that the central nervous system does play a role in this situation. If you lose weight, if you're stressed or sick, you're going to shut down this system. I can't think of too many things that activate it, but usually the central nervous system might be more inhibitory than active here. As in women, I'll repeat it here because some of the men might not have watched that episode. The control of gonadotropin-releasing hormone, or GnRH, from the hypothalamus is regulated by the pulsatile action of the arcuate nucleus, which sets a pulse rhythm to make it happen about every 90 minutes, so that every 90 minutes we produce GnRH, and that causes the pituitary to produce LH and FSH. This pulsatility of GnRH is very important. If it's not present, then you don't produce LH and FSH. If I give you too much GnRH as a continuous infusion, it's going to shut down LH and FSH. There are drugs that can be used in men with prostate cancer that act like GnRH and shut down LH and FSH because it's a continuous flow of that hormone to the pituitary. However, in patients who are normal, we have to have pulsatility of GnRH to make LH and FSH work. That's also been proved in studies of men who have reproductive dysfunction of their pituitary, that if you give them, or their hypothalamus rather, if you give them GnRH every 90 minutes by an infusion pump, you can lead to normal fertility. So it's fascinating that it requires that 90-minute pulsatility for the pituitary hormones to do their job. Once LH and FSH are secreted, they do different things. LH travels through the bloodstream, and it ultimately goes to the testis and binds to the Leydig cells, the LH receptors on the Leydig cells, which produce testosterone, which enters the bloodstream and can inhibit LH production and also inhibit GnRH production. And in this way, through negative feedback, it basically regulates it at a level where you're not making too much so that your testosterone level doesn't go too high. So it goes back to our negative feedback concept that we talked about on some of the earlier episodes of Pituitary 101. The FSH produced by the pituitary gland actually stimulates the Sertoli cells, which are in the testicles, and the tubules in the testis, which are basically the nurse cells that allow for maturation and development of mature sperm cells. And it takes testosterone in the testicle and the FSH doing its things with Sertoli cells to lead to normal spermatogenesis and the ultimate release of sperm. There are some other proteins produced by the Sertoli cells, namely inhibin, which can inhibit FSH, and I think activin can stimulate FSH. And those are important hormones that sometimes can be checked in patients if you think they might have pituitary or testicular dysfunction. You can sort of identify the site of where the problem is. One of the things that I want to go through carefully is the fact that most of testosterone secreted in the bloodstream is bound to proteins. In fact, only 2% of testosterone is free. Many of the testosterone assays look at total testosterone, so they're going to tell you the testosterone level of all the testosterone bound to sex hormone binding globulin and albumin and some of the lipoproteins and the cortisol bound testosterone. So that basically there's a big discrepancy between the free testosterone and the bound testosterone, and what we call the bioavailable testosterone, which is everything that's not bound to sex hormone binding globulin. The pituitary works to regulate the free testosterone, and that's really what's most critical. If you look here, total testosterone, albumin, and sex hormone binding globulin, and free, these are in equilibrium, which means testosterone's coming off and on these proteins into the free compartment as the free testosterone gets converted into dihydrotestosterone and is utilized in cells and internalized into cells. So that we have the regulation of the testosterone is really based around the free level. Sometimes laboratory assays look at just the free level. Sometimes they look at the free and the total. Some assays will look at the levels of sex hormone binding globulin as well to allow doctors to interpret what's really going on so that we can make decisions about whether there's adequate function of this axis. When it comes to negative feedback mechanisms, I want to return to our previous slide and share with you that in men who take too much testosterone, you're going to shut off your LH and FSH. So that if you have testicular failure, your LH and FSH can be used to determine whether you're on too much testosterone. If you have pituitary failure, we can't tell that because your LH and FSH are already abnormal. Little bits of testosterone will suppress it if it's normal and don't necessarily mean you're on too much. So we have to look at testosterone levels in that setting, and that's where it's important to recognize that the differences in the total and the free and why we must actually follow that free level to know whether your levels are adequate. There are different genetic conditions that can change the levels of these proteins, and that will change the level of the total, but the free will be normal. I saw a patient yesterday who had sex hormone binding globulin deficiency that's probably genetic in nature. His total testosterone level was frankly low, but his free testosterone was entirely normal, so I was able to tell him that his pituitary gonadal function was normal. In fact, all his pituitary functions were normal, despite the fact that he had a pituitary tumor. But knowing that his free testosterone was normal and not really low because the total testosterone was low was important decision making, so I didn't have to treat him with testosterone. And as would be expected, he didn't have any symptoms and signs of testosterone deficiency either. This is a really important slide that shows several concepts, and one of the important things that it doesn't show, because this is age-related basis, is that testosterone levels are higher in the morning. So if your doctor is really wanting to know what your testosterone levels are, go get them done in the morning. If you're on treatment, that will need to be modified based on whether you're on injections or gels or oral therapy. Usually we would still say morning for most of those, but you might get it on a certain day after an injection, for example. One of the things that you can see here is over time, again, this is men from 40s to 80s basically, on the bottom axis, and it shows you here that testosterone levels look to be fairly stable through age, just a slight diminution over time. And you can see the different lines are obese versus non-obese men. Let's look at what's in the green. You can see here testosterone levels are fairly stable over the period of age, but look what happens to the free testosterone levels. They decline with age. This is a normal process of aging. Why is the total the same but the free is normal? If the body is regulating the free, why is the total staying the same? It's because sex hormone binding globulin levels increase with age. So even though the total is the same, the free is lower because most of us bound to sex hormone binding globulin. We consider this to be normal aging, and we try to treat men with testosterone replacement such that we match an appropriate age normal range. And that's the way we've always done that. But you look at a graph like this and it makes you wonder, is that really the way we should be doing this? Because look at this graph, it's showing you what happens to LH levels over time. And you can see that over time, as the free level is dropping, the LH level is rising. I see a lot of men, they have LH levels that are 15 or 20 or so, and they wonder what's wrong. Their testosterone level is normal for age. Maybe these people really have testosterone deficiency, and the pituitary is telling us that this patient has a testicular problem with a low normal testosterone that's too low for them, and that's why the LH is high. We see the same in men who lose fertility due to chemotherapy drugs. Their FSH levels will rise but their testosterone levels will often stay the same. But I look at data like this, and I often wonder, we adjust testosterone so that we don't cause problems with replacement in elderly men, so they don't get prostate enlargement or high hemoglobins or high cholesterol levels. But what's the pituitary telling us in those men that have primary testicular failure? So it's worthy of consideration. It's part of the normal function of the gonadal axis during aging. But it suggests a little bit of a testosterone fall as women have a fall in their estrogen production with time as well. So when it comes to looking at patients who have hypogonadism, I do check their testosterone levels, their LH and their FSH, and try to relate it to their age and to see what I'm expecting. Again, it's a correlation of the anatomy, the physiology, and the clinical symptomatology. And sometimes we have to make a judgment. I had a recent patient who had a testosterone level in the low normal part of the free range, but he's 25 years old. His level should be in the middle or the high part of the free range. So I tell a patient like that, I think you have hypogonadism and you need treatment. If the patient were 80, I would say, look, I probably wouldn't treat you because your level's in a low normal range and that's where it's supposed to be for your age. So we make these judgment decisions based on the clinical context, and that's the way all of these laboratory results should be interpreted in our patients. Sometimes we have patients on treatment who have normal levels of testosterone, but their hemoglobin's risen, their cholesterol's worsened, and their PSA's risen. That's a patient whose body's telling me they're on too much, so I ignore the number and lower the dose of the medication for their overall health and benefit. So that's how complex the interpretation of these results can be, because we have to look at those other situations as we're trying to decide how to interpret and when and how to treat. In closing, I want to discuss the other rare condition I mentioned in the women, that sometimes we have pituitary tumors that produce LH and FSH, and they're functional, and they will overdrive the gonadal axis. And I've had several men, probably 1 or 2 a year, who have very high testosterone levels for their age, even frankly above the normal range for teenagers. And it's because their tumor is producing LH and or FSH, usually the LH driving testosterone production. And one man who was in his 70s and had fathered several children in his 70s because he was hyper-fertile, if you will, due to his FSH-producing pituitary tumor. So it's all very interesting, and those are some of the things that I think are important to know as a patient about this hypothalamic pituitary gonadal axis. I hope you've learned something, and stay tuned for future episodes. Have a good day.
This is Jorge Fascinetti, co-founder and chairman. Pituitary World News is dedicated to produce content that informs and educates. We are a nonprofit organization, and as such rely on contributions to fund all these initiatives. We have exciting plans for 2025. If you'd like to learn more about our plans and help, please visit pituitaryworldnews.org and click on the donate button. Every contribution helps, no matter the size. You can also help by sharing all the information available on the Pituitary World News website at pituitaryworldnews.org. We welcome your comments and suggestions. Thank you, and thank you very much for watching.